Welcome to today's ME SUD Learning Community webinar. Today we'll be hearing from Jennifer Rogers on integrating HIV testing into street outreach for unhoused Mainers. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions of the speaker in this webinar series are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time, or you can place them in the chat. And now I'd like to give a quick introduction to our speaker today. Jen Rogers is a Ryan White HIV/AIDS program nurse practitioner who has been caring for people living with HIV and viral hepatitis since 2005. A former member of the Maine HIV Advisory Council and the New England Division of American Foundation's Medical Advisory Committee. She holds an HIV specialist certification with the American Academy of HIV Medicine. Jen is honored to work with her patients in Greater Portland Health. And with that, I'll hand it off to Jen for our presentation. Thank you all for being here today.
Thank you, Bethany. Hey, everybody. Thank you for inviting me to join you today. Let me just share my slides. Okie doke. And yeah, there should be plenty of time for questions at the end, but don't hesitate to interrupt me if you have any questions or need clarification during the talk. I can't see the chat, so Bethany, would you just
Yes,
feel free to interrupt me? Yeah. All right. Yeah, so I'm Jen Rogers. I've been taking care of folks living with HIV and viral hepatitis for over 20 years, and most recently at Greater Portland Health, which is an FQHC in Portland, Maine. I've been here since starting the HIV infectious disease program here in 2016. And I work at 4 different sites, 2 of which are healthcare for the homeless sites, and have done a lot of outreach and taking a pause on outreach, but we'll be starting outreach again one morning a week in a couple of weeks. Today, I'm going to review the risks for HIV acquisition in the setting of homelessness. I'll review FDA-approved HIV testing options, share outreach strategies for people experiencing homelessness, and discuss how to integrate HIV testing with outreach and street medicine. And as I think many of us in our state are well aware, there's a real connection between housing costs and homelessness. And I think that this chart is super helpful and clear. The blue line that just is like shooting straight up starting around COVID is the number of people who are experiencing homelessness. And then the dark green line, which precedes it by a couple of years, is the cost of housing. And you can see they're just parallel connections between the two. And in 2024, there was a record number of Americans who were homeless. And this was like shockingly, it was an 18% increase compared to 2023. And 2023 was greater than a 10% increase from the year prior. So it is not only just not going away, but it is becoming like exponentially a problem. And so this graph, the top line is all people who are experiencing homelessness. The middle line or brown line is people who are experiencing sheltered homelessness, meaning they're either in the shelter system or doubling up somewhere. And then unsheltered homelessness is the lowest line. HIV in the United States, there's fewer new infections every year. However, in 2022, which is when we last have data, there was 31,800 brand new HIV infections in the US. And while there's like a distinct geographic distribution where like most of the new infections are in the southeast. This is absolutely, we have new infections in Maine, and and um, and this is a big number still. This is a graphic of transmission care categories for all people living with HIV, and about 2/3 are have been exposed through male-to-male or MSM sexual contact. And then breaking that down, females, almost 20% acquire HIV through injection drug use, much greater percent than males, and then not in this in these statistics, but super importantly, transgender women, they actually have the highest incidence of HIV of all populations, greater than 80 or 20%, it's estimated, most of which are sexual transmission. And in some cities, the incidence is greater than 40%. This is the HIV care continuum. I'm not sure whether y'all are familiar with this or not, but this is what is used looking at how well we're doing nationally with making sure that everybody who is living with HIV has been diagnosed, which is the little box on the left, and then linked to care, receiving care, importantly, retained in care. And then the ultimate goal is achieving and maintaining viral suppression. Not only is we want this to be 100% through this whole continuum, but especially on the right, because not only will that reduce morbidity, mortality for people living with HIV, but it will reduce the community viral load, so there is less transmission in the community. And so we are not there yet. This is what the continuum looks like from 2022, which is the most recent, where we have most recent data. And so 13% or greater than 158,000 people are not even aware of their diagnosis. And so potentially unknowingly transmitting the virus to other people. Moreover, almost a quarter of people living with HIV are not in care, and so at risk for transmitting the virus to people, so either knowingly or unknowingly. And the rates for viral suppression has improved a lot in the last 10 years, especially within Ryan White programs. And Ryan White programs are HRSA-funded programs throughout the United States that provides really comprehensive support for people living with HIV, usually within a big medical home like an FQHC. And that's where I work. We have 3 Ryan White programs in Maine. And the viral suppression rate is not nearly so robust in non-Ryan White programs, 65.1%, which means that there's like, 35% of folks who are living with HIV who are not virologically suppressed and therefore at risk for transmitting the virus to other folks. And then, as you can imagine, the care continuum numbers are worse in the setting of homelessness, just because of the complete chaos and stress that people experience when they're unhoused. So, of all people living with HIV in the States, it's estimated that 17% are experiencing homelessness or unstable housing. And the rate of viral suppression for these folks is much lower than those who are stably housed. And just the overall progression of going through this continuum from the time of diagnosis to being virologically suppressed is estimated to be about 44% lower. And so what kinds of testing is there available? I'm going to go through these and really just thinking about how best to use these tests when doing outreach for unhoused individuals. So there's three ways of testing for HIV. So we have serologic testing or blood testing. We have point of care with a finger stick, which is that middle picture. And then we have self-test kits, which are a cheek swab. And before I go over each one of these types of testing, I want to just share this slide, and hopefully it's not too confusing. So there are really like there's a bunch of markers if somebody is living with HIV, and the markers will become apparent depending on what marker it is and from when somebody was exposed to HIV. And so the most sensitive, the marker that we will see the first is the viral load. So in this chart, it's the blue line on the top, so plasma RNA. So that's the HIV viral load. That can be detected through a blood test as early as 10 days after exposure. And then the next marker to show infection is the HIV antigen. And so this test specifically looks for the P24 antigen, which is an HIV protein. And so the antigen becomes detected about 2 weeks after exposure, 2 weeks to like 3 weeks after exposure. And then finally, the antibody, which is sort of the last one to become apparent, that is detectable about 3 weeks after detection. And the current blood tests that we have now are what's called fourth generation HIV antibody antigen tests, which is that middle line. And that's like standard of care for when you have somebody screened for HIV, they get a blood test. That's what they receive is the fourth generation test, and so you will see it will result as it checks for both HIV-1 and 2, two different strains of the virus. The vast majority in this country is HIV-1, and will check for HIV-1 and 2, and then the viral load, which we check, which is a separate blood test, and that's a NAT. And so those are the two blood tests that we use to check for HIV. And then there's a point of care antigen antibody point of care test. The only FDA approved one is called the Abbott Determined HIV-1/2 antigen antibody combo. It's a finger stick, just like getting some a blood sugar on somebody. It takes 20 minutes, and it's really sensitive. It detects presence of HIV 12 to 26 days after exposure. And so this is available free for folks interested through the Maine CDC. So folks need to complete what's called the Counseling, Testing, and Referral Training, or CTR training, through the Maine CDC. And I'll talk a little bit more about this later. But once you complete this, these tests are available free for anybody in the state. And then finally, there's the self-test kit. And so it's called OraQuick, and it's a cheek swab, and also 20 minutes, like the finger stick. And it is got 99.9% for accuracy if the test is HIV negative, and about 91% if the test is positive. And as you can see in the bottom photograph, it's a bit like a pregnancy test where one line is negative and 2 lines is positive. And this test, which is really well packaged for low health literacy, it's super, super easy to figure out how to use it if you are not medical. This is what we primarily use when doing outreach, and these tests are available for free through Franny Peabody Center, which, for folks who don't know Franny is what's called an AIDS service organization in Portland, Maine, and they provide medical case management as well as prevention services for HIV, and including they have a grant to give these tests out for free to anyone in the state who might want that. And so the executive director is Katie Rutherford, and she said it was totally okay for me to share her email address for folks who want to connect with her about how to obtain some of these self-tests. Okie doke. So HIV testing and care for people experiencing homelessness is really most successfully done through the healthcare for the homeless care model, which is a very, very different way of providing care for folks than sort of a traditional medical office. And pretty much everything that you would normally do in a traditional medical office, you can just throw that out the window because the approach for taking care of these folks is really truly as low barrier as possible, and needs to be really patient or person-centered and trauma-informed. And so what that looks like physically is you can have a brick and mortar clinic. We have one at Greater Portland Health that is right on the corner of Oxford and Preble Street, within walking distance to general assistance and multiple community organizations that support people who are experiencing homelessness. And then it's really important for a healthcare for the homeless model to be in places where people experiencing homelessness can be found. And so that includes co-location in homeless shelters, co-location in Housing First sites. So Housing First is very supportive housing for people who have experienced chronic homelessness. And then recuperative care, which is also called medical respite. And what recuperative care is sort of a bridge between the hospital and the street. So it's for people who are experiencing homelessness and they were sick enough to be in the hospital and too sick to be discharged to the shelter, to the street, and would risk both like morbidity, mortality, as well as likely readmission. And so recuperative care provides care for these folks. And in Portland, we have a recuperative care program that's a collaboration between Greater Portland Health, Maine Medical Center, and Preble Street. And then finally, an essential part of the healthcare for the homeless model is street medicine, which I'm going to talk about in just a little bit. It's incredibly important to avoid rigidity when caring for these folks. And so, there's never any punitive action if people miss appointments, and there should always be available walk-in slots for people who feel safe enough to walk in the door to request care. And so at GPH, we have openings in the morning and the afternoon, 5 days a week, as well as some 1 day a week. We have some evening appointments or walk-in availability. And it's so important to acknowledge and appreciate that the most important goal when caring for people who are unhoused is to develop a trusting relationship. These people have experienced just profound trauma within the medical system as a whole, and being treated differently because they are homeless. And so if somebody comes in and their blood pressure is 200 over 100, and they really just need are asking for a clean, dry pair of socks. That's how you start. And if they're not ready to talk about their blood pressure, that's okay. It's a really long process for a lot of folks to trust a medical system, not just providers, but everyone within the system. And so it really needs to, a successful healthcare for the homeless program needs to be patient directed. So this is what GPH's Healthcare for the Homeless program looks like. So we do provide general primary care. And in addition to that, we provide daily and weekly dosing. So a lot of people who are unhoused are at risk for losing medications or having meds stolen. And so some people will come in every single day or 5 days a week, and then we give them like a little envelope for the weekend for their medications. Some people will come in weekly, so once a week they'll come in for their meds, and they're often we work with a pharmacy that will bubble pack daily meds. We offer injectable and oral MAT and ART or HIV antiretroviral therapy, harm reduction supplies, family planning, viral hepatitis care, same-day STI treatment and prevention. We have a dental program with 3 dental operatories, substance use, community health worker and peer, actually a couple of peers. The Ryan White program has a cell, so we can text and WhatsApp our patients, as does the substance use CHOW, or community health worker. We have nurses, Ryan White or HIV CHOWs. We don't have a specialty pharmacy co-located, unfortunately, but fortunately, there's one upstairs. So we spend a lot of time Monday through Friday running up and down outside to Genoa, which is just above us, and have a super close relationship with them. We provide social work, food, clothing, transportation assistance, camping gear, and people can have their mail delivered at GPH as well. And in order to do a good job, is such hard work. It's incredibly rewarding, but it is hard. The level of suffering that you witness is just unimaginable at times. And so it's just essential to have a strong team. Every single person in the team needs to be able to work well together and have a degree of humility, compassion, non-judgment, be supportive of one another, and a sense of humor is super helpful. And this is a picture of us on like a opposite day as today. It's a beautiful, warm, sunny July day where we go every year to the East End to have an annual kickball tournament and just close the clinic and have fun. And, we do smaller things like that throughout the year, but just so important to be able to goof off and have fun with one another because the work is sometimes really hard. And healthcare for the homeless model can't succeed without strong community partnerships. And that includes the police and the police behavioral health liaisons, one of whom, his name is Bill Burns. He has my cell phone, and it's not uncommon for him to call me and say, "Hey, Jen, I have this gentleman. He is really eager to restart his HIV medications. Can I bring him in now?" "Yes, please bring him in now." And these relationships are essential because we can't do this alone. And that includes the jail, pharmacies, outreach organizations. So in Portland, a big one is Milestone, which provides 6 days a week outreach in 2 different vans. Food banks, shelters, syringe service providers, detox and recovery facilities. And then just a little bit about street medicine. So there's a lot of people who are experiencing homelessness who, for various reasons, do not feel safe at all coming into the clinic. and will not come into the clinic. And so it's essential that we are able to meet them where they feel safe. And so at Greater Portland Health, we do outreach 3 days a week, and we use both our feet and the van. And so this picture on the left is the Tuesday afternoon crew. Amy on the left is a nurse practitioner. Aaliyah in the middle is a substance use chow, and Erin on the right is a medical assistant. And so in the very front, there's a black medical bag, which has things like paperwork for anybody who's not a patient, who's interested in being a patient, and then Tylenol, Motrin, topical antibiotics, wound care supplies, Narcan, and then the big wagon, which is used with outreach, includes things like water, snacks, socks, hand warmers in the winter, suntan or sunscreen in the summer. And then the van, which is pretty new, is great because we're able to do phlebotomy in there, and it can park outside of usually community outside of our community partners. So for example, Kevin Sullivan, who's the medical director for the program, he goes to Common Space every Wednesday morning. And for anybody who is there who thinks they need a medical visit, they can walk outside and go into the van and receive medical care in the van. So how to integrate HIV testing with street medicine. Really important for staff to be trained to talk about HIV testing, to know what they're talking about. And so as I said earlier, there's a free counseling, testing, and referral training through the Maine CDC HIV STI prevention program. And the contact for that is listed right here. And they are great. They will create a training for you in your with your organization. It's a 1-day training. And then once you complete the training, you need to be able to do you need to have 5 HIV tests witnessed by a trainer, and then you're free to fly. And once you have completed the training, as I said, the test kits are free through the CDC. So staff needs to know what they're talking about. The staff must be trusted by the community. It does not need to be medical, but most important thing is that they need to be trusted by the community, and there needs to be a really clear linkage to care if the test is positive. So at GPH, we try to have any new HIV diagnosis seen by me within a week at the absolute most. 72 hours is really the goal, and can see people outside or inside, whatever the person is comfortable and feels safe doing. But you can't just expect to give people tests without any plan for if the test is positive. And so for the self-tests, which are sort of in these plastic boxes, it's suggested that you would put who the contact is if the test is positive, right? So is it like somebody within a public health system? Is it a different organization that that is really trusted within the community where you're giving these tests out? Whoever it is needs to be somebody trustworthy enough where the patient or the person can communicate with them, and that there needs to be a very clear way to reach this person should the test be positive. And then it's so important to integrate HIV testing with all harm reduction, right? So that includes SSP, fentanyl test kits, wound kits, Narcan, MAT, and then HIV PrEP, which I'm not going to talk about because I think that there was a recent talk about this, but um, HIV pre-exposure prophylaxis is essential when talking about HIV prevention as well. And so to summarize, HIV prevention includes free access to self-tests and point-of-care tests. It should include access to MAT and harm reduction. It should be integrated to outreach for people experiencing homelessness. Self-test kits should be part of any outreach bag to be able to hand out when people are open to receiving them. And then linkage to care is an essential part of distributing self-test kits. And I realized that I just like flew through that, and we have a lot of time to for discussion, and I'm more than happy to answer questions or have discussion.
Thank you so much, Jen. It looks like we do have a question in the chat. Do medications lose effectiveness if someone comes on and off the medication?
Yeah, that's a great question. Are
I
you
would
talking
imagine
about
that.
the HIV medications? Is that what you mean? I'm assuming.
Yes.
Yes.
Yeah.
Yes.
Yeah. So that's a really, really good question. And the short answer is yes. So the medications that we have right now have really, really, really robust barriers to resistance. And so especially with a couple of the first line oral medications, it's they have really high barriers to resistance, and so so you can go on and off of them, not safely, but I have never seen any resistance to the sort of two main medications. It's entirely possible, and for that reason, oral medications, well, that's one reason why oral medications might not be the ideal meds for this population, because of the level of just like stressors and chaos that people experience. Remembering to take a pill every day is definitely not at the top of a lot of people's priority in terms of just surviving a day. And so we're really fortunate to have injectable HIV medication, which is an injection that people can receive every 8 weeks, so 6 times a year. The first 2 are a month apart, but then after that, it's every 8 weeks, and can be given like through the van that we have. People can come in and receive their injection, and that is just like a much better HIV medication for this population, because they don't have to worry about losing meds. The problem with that, of course, is like trying to find people to make sure that they stay within that 8-week window, and you're not always successful doing that, but that is a really good option for this population. Good question.
Any other questions can be placed in the chat, or you can raise your hand and unmute. John?
I guess I'm also just wondering, like, do you anticipate any issues with funding given the current political climate?
The great question. I don't know. I don't know. I know that, as you might already know, a lot of the guidelines disappeared on January 31st, and some of them have returned, but some of them aren't. Like the PrEP guideline is still not back online. I think it's a little early now to know what's going to happen. I know historically Ryan White programs have received like really strong bipartisan support, but I think I don't know. I hope so. It's a good question. I hope so.
Thank you for that question, John. Jen, I have a question. Were there any questions that you hoped to get asked today?
I That's a good, I don't have any, no, I don't think so, but I'm just curious whether folks who are listening, whether anybody's doing outreach to unhoused folks. Nope.
You can
Okay.
either put it in the chat or, yeah, if
Yeah.
you are doing outreach.
Yeah. Oh, great. Nicole Butler. Great. That's great. Do you have HIV self-test kits?
Looks like Kevin has his hand up.
Great. Kevin.
Yeah, I just wanted to say that I do outreach and I help facilitate a warming center. So I do a lot of different outreach with people experiencing homelessness and substance use disorder. And I also had another question. How would like somebody that wanted to help support your mission get involved, or either as a volunteer or in a paid role? Because I do have some outreach workers that are looking for more opportunities.
Wow, that's great. I can put my email address in the chat and uh,
I can also include it
there
in
it
the
is.
follow-up email. Oh, there it is. Yeah.
Yeah, there it is. Feel free to email me. That's awesome. Where do you work?
Okay. I operate New England Calvary, but I also work with other agencies like Chucky's Fight in New Hampshire and Carly's Home Team and community partners.
Oh, that's great. Yeah, you feel free to reach out to me later. That's wonderful.
Thank you.
Yeah.
Thank you, Kevin. It looks like we have a couple comments. Jessica says, yes, that they are providing supplies to MAP and Opportunity Alliance. Jessica says they've just purchased HIV tests from Fannie Peabody. Nicole says, we do. I work at Main Access Points and we are starting dry blood spot testing too.
Great.
Sandra says that she's not doing outreach, but I believe that our harm reduction team is doing the outreach in Bangor.
Yeah. That's great. Yeah, I know Bangor is doing an amazing job with distributing self-test kits to a large encampment in Bangor where there's currently an HIV Hep C cluster, and the public health, Bangor Public Health is doing an awesome job with that, with distributing that, the tests.
And then Sanders said that harm reduction does HIV testing in office.
Great. That's great. Great.
Well, and from what I'm seeing, it looks like a lot of these are, population dense areas. How does this look different in more rural settings?
Yeah, it's a good question. I think it just really speaks to the importance of having community partners who work with, it's just so hard, so much harder to reach folks in more rural settings, and even like some of the challenges that the all the people who are working with the Bangor encampment are facing, because it's a little bit more rural, just in terms of like even having good Wi-Fi to be able to use an EMR or to communicate, use the phone and pick up the phone to call a medical provider. That is a big challenge there, or has been. And so yeah, and so just making sure that there is access to HIV testing in any way possible in more rural communities, because it's everywhere in our state. I just saw a 65-year-old Mainer last week with a brand new diagnosis, who lives in rural, well, like outside of Portland, probably 45 minutes from Portland, so not as rural as Madawaska, but pretty rural. And he comes to Portland occasionally to hook up with folks, and unfortunately is a new diagnosis. So it's here in our state, and we can't assume that it's not. We can't assume that that people can't acquire it in rural areas because HIV is in all counties in our state, and we are not there yet with everybody being on medications who should be.
Thank you.
Can minors
John?
consent for treatment?
For treatment? Yes.
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 Okay.
Yes. Good question. Yes.
Yeah, I can appreciate how difficult it
Actually, I
was,
will.
or is. I did an internship at Preble Street, and there was a client who thought I was a police officer the whole time, and I was I was an MSW intern,
Yeah.
So, but yeah, there's just a lot of barriers, including mental health.
Yeah. 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 And often, being able to engage. Sorry. I just saying often in being able to engage with folks, that's you will find somebody who the person trusts most, and it could be anybody. It could be a peer, it could be anybody in the community, and they can be the bridge to saying like, oh, Jen, she's cool, you can trust her, it's okay. And yeah.
That was a great question, John. Kevin wanted to share if anyone wants to network or connect or to collaborate. He shared his contact information, which is
Great.
such a wonderful thing about the learning communities that we are able to virtually collaborate and connect. So thank you for that, Kevin. But Jennifer, is there any other big takeaways you want us to wrap up with?
I don't think so. Thank you.
A webinar on stigma and HIV, which I think is a big, I'm sure, Jen, if you have any comments on stigma and HIV?
Yeah, there's a there's a lot of stigma in HIV, including in the medical world. It's continues to shock me how much stigma and ignorance there is around HIV, and which can contribute to people not feeling comfortable coming in to get tested, and as well as just a ton of internal stigma around HIV. Yes, true. So that's great. I'm looking forward to that in April.
What do you do to help combat that? Or like, do you have any phrases or, scripts that help that?
I think that treating people with compassion and respect goes a long way, and really making sure that the environment feels safe for people so that they can so that you can develop a therapeutic relationship with the person. And so that includes like the entire team being aware of what challenges there are living with HIV in Maine, whether you're a new Mainer, and like the fear that people in the community will find out about their status and then exclude you from the community, or if you're not a new Mainer, if you're a Mainer, and so I think that also access and being able to be seen by providers quickly is helpful. And we have a cell phone that people can text or send WhatsApp messages, which bypasses the whole call center. And so we have one point of contact. His name is Matt. He's a Chow, and everybody knows him. And so he's a part of the team, and he knows our patients, and it's really, I think, helpful for people to be able to reach out to him directly rather than have to speak to somebody in the call center to explain that they need to talk to me or see me. So that can be helpful as well. We provide HIV care at most of our sites, so people don't have to leave their medical home to receive their HIV care. And that also can be helpful. Yeah.
Those are all awesome, options. I want to give an opportunity for any other questions before we wrap up. And if we don't have any more questions, thank you all so much for joining us today. Thank you, Jen, so much for your presentation.
Yeah.
We hope to
Thank
see you all again soon.